Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast, and today I am with Andy Fisher, and we're going to go over co-administration of ketamine and Versed. Andy, if you wouldn't mind, just quick, I'll introduce yourself.
Hey Dennis. Always a joy to talk to you. I think this is about the third or fourth time I've been able to do a podcast with you. I'm Andy Fisher. I am currently a general surgery resident at the University of Mexico. I am still a PA in the Army National Guard. Previously, I was assigned to the 75th Range Regiment and the Army Special Operations Command as a PA before attending medical school. I am a member of the Committee on Technical Combat Casualty Care and recently led the rewrite of the guidelines for analgesia and sedation for TriC.
Very good. So you are definitely the guy I want to talk to. So I guess, why is it so far that, really whenever we're talking about giving ketamine, pretty much just about in any situation, they always talk about, well, you have to add, 1 or 2 milligrams of Versed. Why do we do this?
I think it's been, I would say, protocolized for reasons that we've kind of been passed down over time, by the past 10, 12 years or so of ketamine administration, that we seem to believe that, you need some sort of amnestic property, or you need something to prevent them from having some sort of reaction. Even if you look back to my early use of ketamine, I was using a lot of Versed because I just thought that's what you needed to do. And, and it was based upon, patients moving and having maybe a little bit of unpleasant, sensations and such. And that's, I've kind of changed my opinion on that because, I've kind of looked at it now, I've kind of grown up, given a lot of ketamine over the years. And I've seen probably where some of the errors of my ways and have now tried to shift away from, giving midazolam or Versed whenever I give ketamine.
Okay. So, and everybody talks about, these emergence reactions, or, when I was given ketamine, like I did not like it at all. I saw a lot of scary things. Like, I guess, since seems like there's a great big spectrum, what exactly is an emergence reaction?
Yeah, there's a problem with that because there's no great definition of it. Overall, we kind of use this idea that people have some unpleasant sensations. They may have some sort of disconnected, floaty. They may have hallucinations, maybe somewhat agitated. They may even have euphoric. It's really kind of hard to say what it is. And it's not even necessarily emergence reactions. It's you can have these issues as you give ketamine also, and so it's not really necessarily, I wouldn't say emergence, but just overall a spectrum of these issues and unpleasant sensations that may occur in patients. With most of them probably being not something that requires treatment. But we've kind of got this idea that any sort of unpleasant sensation needs to be treated with ketamine, or retreated with Versed.
Right. And I think, part of that is, that unpleasantness. It's like our kind of like human desire to, take away somebody's pain, to take away their discomfort, to make everything better again. And, now might not be the time for me to worry about that. You know what I mean?
Mm-hmm. Yeah, exactly. When you give someone ketamine, it's a dissociative anesthetic. Now, are you giving them an analgesia dose? If you are, you shouldn't necessarily have significant disruption of their mentation. If you give a sedation dose, certainly you're going to, put them into a state of dissociation, where they shouldn't necessarily have any sort of memories of whatever procedure you're doing. Now, they may have dreams and such, but a lot of people don't necessarily recall what has happened beyond, I was in a stage where I didn't necessarily know where I was or something like that. Mm-hmm. So it's one of those things where you have to kind of evaluate what you're doing. And again, if you put someone into sedation, they shouldn't remember necessarily. And if you're doing analgesia dosing appropriately, they shouldn't have significant alterations in the mentation.
Right. So is this more of a dosage problem of ketamine, or is this more of a the provider is not actually targeting an actual signs and symptoms? I guess they don't have an actual goal in mind, and they're just kind of giving ketamine until they feel better about themselves.
So I think one, we know there is a dose area that generally causes some sort of, or has a higher incidence, I guess, of causing some unpleasant sensations, and that's generally from about the 0.5 to 0.8 milligrams per kilogram, maybe even lower to like 0.4 milligrams per kilogram. But there's also some issues that have to do with how fast you're administering it. There's been studies that demonstrate, hey, if we put this in an infusion and give it over, as short as 3 minutes, but as long as 15 minutes, that people have significantly less unpleasant sensations. So you have to be mindful, yes, of both what's my dose and how fast am I pushing it. Mm-hmm. I think in a pre-hospital setting, even a hospital setting, these situations where we have traumas, you're often giving ketamine in a syringe, and you're like, oh yeah, everything is what we call slow IV push, which is really just a standard IV push, right? Because rarely do people actually, I think, you just say, well, I'm going to give this over 2 minutes. So yeah, I think putting a little bit of ketamine in a small bag and administering it would greatly, I think, decrease some of these issues that people run into.
Right. And that's just ketamine. I mean, that's multiplied, I think, over far above that when you're talking about Versed. Ketamine, you push it quick, it's unpleasant. Versed, you push it too quick, it can be deadly.
Yeah, you stop breathing. Which I had a patient that in Afghanistan stepped on an IED, kind of got his foot blown off up to about his tibia and fibula, just above the ankle, and gave him some ketamine, and then thought it was a little bit of Versed, and he went apneic on me until I had to give him a little sternal rub to get him to breathe again. I didn't have to intervene other than providing a little bit of just a little bit of
pain stimulus.
Yeah, pain stimuli. So yeah, that was pretty effective. But it was certainly something I was like, oh crap, what am I doing here? Mm-hmm. So a little bit of an eye-opening moment. So I know that it can happen, and you have to be very mindful of that. Especially, that may be both rate and dose related too, right? So if I give too much Versed, you can do that, and obviously if I give it too fast, I can probably do that too.
Right.
And let's not forget also that people think that ketamine is like this drug that's going to support your respiratory, your cardiovascular status. It's not going to cause any significant issues. But if you push it too fast, you could cause hypotension, you could cause bradycardia, you can cause apnea. So you have to be mindful of that too. That just because the profile of ketamine says that, hey, it does this. There's also these adverse events and effects that can happen by probably inappropriately administering it.
Right. Well, most of the dosing you look up, one is built off of healthy people. That's how they built their dosage profile. Two, there you have, pharmacokinetic, pharmacodynamic effects when they're just looking at the molecule itself. But people forget, you're adding that to a sick patient, and you're going to have other effects, So even if the drug works and you take away his pain, his blood pressure can come down just because you're blunting that sympathetic response.
Sure. Yeah, that's always a possibility too.
Right.
Yeah. Yeah.
Um, so I guess other than pushing it too fast, all right, what's
Yeah.
like really the downside of just every time you add ketamine, just add a little Versed? Like, really, what's the big deal?
Well, I think it goes back to the idea of polypharmacy and those synergistic effects that can occur with it. You can, like I said, you can cause things like apnea and hypotension, cardiovascular collapse with Versed. Given a low dose, it's less likely to happen. But as we get into these patients that are acutely and severely injured, and then we're starting to administer different drugs, and then what happens when that gets in the pharmacodynamics, like we talk about pharmacodynamics, pharmacokinetics within the body, and these drugs that given a significantly injured patient who may be already hypotensive, and that's the issue, is we risk potential apnea and cardiovascular collapse.
Mm-hmm. Yep, absolutely. And if you're pushing drugs like that, often guys aren't quite as prepared for things like that as they'd like to believe they are.
Right. Yeah. I mean, I think I felt pretty prepared. I felt like I was prepared, and here I go. I caused a guy to stop breathing momentarily. It's in the middle of the night. We're waiting on the bird to come in. We're in a gunfight. 100 meters away, they're still shooting. So what? Was I really prepared for that to happen? What happens if he didn't respond to my painful stimuli? What would I have to intubate him then? And that was a small dose. That was probably 50 milligrams of ketamine. So I was doing a little bit higher dosing, but the guy was not a small guy. I mean, he was a pretty big guy, and it was like 1 or 2 milligrams of Versed, maybe even a half milligram Versed. So, I hear people all the time talking about, hey, it's safe to do. You can give a small dose, 0.5, 1, maybe 2 milligrams, and it's not going to cause issues. I'm like, well, okay. Well, I mean, I hear you say that. That's because you simply haven't experienced that yet.
Right.
And it does happen, and you have to be very aware and acutely kind of watching your patient if you give any sort of Versed.
Right. So, I mean, other than controlling emergence reactions, which is usually when I hear about giving Versed, that's usually the thing that people talk about. Well, I'll control the emergence reactions. He's going to have a nicer trip, right? But I also hear a lot of guys talk about, well, I want the amnestic effects of it. I really don't want my teammate to remember this. This is a horrible experience, and I just want to wipe that all away. What do you think about for that reason?
Well, again, I think it goes back to look at the properties of ketamine. It's dissociative anesthetic, so it should provide that an adequate amount of amnesia by itself. You don't necessarily need Versed to help people forget. And I mean, you can even look at things, other drugs, I should say, that aren't ketamine. So look at the use of morphine even can decrease like the incidence of PTSD. Like, I don't want these horribly injured patients to, suffer, things like PTSD, which is real. And so it's been demonstrated that, providing simple analgesia can help prevent PTSD. So if we're going to give ketamine, then that also helps. And there's been studies that demonstrate, people are always talking about, hey, well, ketamine itself, because of the unpleasantness, can cause PTSD. Well, no, there's already been data that suggests that that is not going to happen. That ketamine is not associated with the incidence or increasing incidence of PTSD. The other studies have demonstrated that actually giving ketamine can decrease the amount of PTSD, and that happens from both the pre-hospital sort of setting all the way back to in hospital. You can still kind of help decrease the incidence of that.
So I guess when is the right time? So we've been talking about Versed and how evil it is for about 15 minutes or so. When is the right time to actually use it?
Let me ask you, when would you use it, I guess? Okay. I'll just throw it back at you. When do you think it's appropriate?
All right. So I think it's appropriate when I've taken care of this guy's physiology. I've stopped all the light threats. I've kind of stabilized the patient, and I've taken care of his pain, right? And and I have some kind of metric to tell me that his pain is under control. Okay. Let's say, but he is continuing to either he just looks incredibly agitated, or he's kind of doing the ketamine hand thing, right? And I'm thinking more of this is a safety type of situation where I really don't want him reaching around, grabbing people's vests and playing with the radios and all kinds of stuff. So I think this is more of a safety thing. I don't want him to like try and crawl away. So just for patient control, then I would start kind of wafting in some Versed. I would start real low. So I guess my plan for using Versed, it's 5 milligrams per ml. So I'll suck up 1 ml. I'll suck up 4 cc's of saline. And so each ml is 1. And I can give it nice and slow, just one at a time until I actually get to a target. And what I'm looking for is I just want this guy to just chill out. Mental status essentially the same, but he just kind of relaxes. And so if I had to put a number on it, like a 0 or -1, something like that, somewhere around there. Yeah. Just so he's calm, he doesn't move, and everything is relaxed.
I think that's pretty solid answer. For me, I'd probably try maybe more ketamine first if I felt someone was a little too agitated, to see if I could get them completely disassociated, and put them in more of a flat anesthetic plane. But there certainly is a time. I think it goes back to what you kind of said, a safety thing. And I would also say, mission comfort help, maybe compromising the mission, right? So is there an issue that he could, hey, I need to kind of make this guy a little bit more sedated, because, compromising what we're doing here on the ground. And again, a safety issue for him, I don't him grabbing at things, or, her grabbing at things. So I think that's probably a pretty solid answer. Anytime you think that, hey, I'm not going to give it initially, it's not protocolized, I will try a little bit of ketamine. If I feel they're getting a little too agitated for me, and if that doesn't work, then maybe a little bit, milligram Versed or something like that, appropriately diluted and given slowly to kind of put them into a plane to where they're not as grabby or they're not making as many sounds, and you can feel like you can safely monitor them. Yeah, I think it's a great answer.
Cool. As far as you were also on the TriC committee still?
Yes, sir.
Okay. So I want to say the last TMEPs, they kind of associated ketamine and Versed together. Are they changing anything like that with the new TMEPs?
With the new TMEPs or new
TriC guidelines? Sorry.
Yeah. So the most recent guidelines are out, and we do talk about the use of Versed. It is, it's in there to be given after I try more, like I said, more ketamine. If that doesn't work, then you can try to give some Versed and see if that works. I would recommend very low dose, and only if, like I mentioned, like mission compromise, patient safety sort of issues, that you should give it. So yes, we did add it in to the guidelines, and I think it's appropriate. And we're not anti Versed. We just would like it to be not protocolized and given more as a as needed sort of situation.
Right. So it's not just like you're saying, not protocolized. So you actually have to think about what you're doing and use the tools given to you, right?
Yes. Yeah. Absolutely.
Cool.
And like I said, I've been down that road, and I've been that guy on the ground that's protocolized it, and I've learned maybe grown. I don't know. I've just changed my view on it just based upon, I think, my better understanding of how to administer ketamine, and also kind of seeing some of the negative effects that can happen with administering it.
Right. Yeah, I think just as we, as you grow, as you get more experience and you get more comfort with the things, the tools that you're given, you understand kind of the ins and outs and how best to use them, and realize that if you're really putting yourself in the patient in more danger by just, giving, unfortunately, recommended numbers, right? So like the book says, give 50, so I give 50. I don't use my brain and think about, can the patient take this?
Yeah, exactly. I think that's the key, and just using your brain a little bit more to kind of understand what you're doing to your patient, and then remedy that and giving the appropriate medication at the appropriate time.
Right. Well, do you have anything else you'd like to add, Andy?
No, I think that's it. Man, I really appreciate you having me on and letting me talk about this. Hopefully it generates a little bit of discussion, and people kind of get away from just automatically administering percent with ketamine.
Yeah. All right. Well, thank you.
Awesome. Thanks, sir.
Thank you.
For today's podcast, be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.